Opa. Hello everyone, thanks for your presence today. Thanks for to be patient because you hear a lot. You hear a lot of theory now. My name is Michele Locatelli. I'm a physiotherapist. I work for a football team in Italy, Atalanta football team. It's a professional football team of Serie A. I work for the first team for 9 years and 4 in the academy. And after the end of collaboration with Atalanta, I started to share the experience through the years. And I'm a laser specialist and trainer for the Italian Academy of Laser Therapy and International Academy of Laser Therapy. Well, we are going to discuss and try directly with my patient and my therapist with the moment. So we are moved from the theory to the table, so a real treatment. So we discuss a lot about frequency, we discuss a lot about wavelengths, we discuss, for example, about laser, about TECAR. What do you understand from this? That you can provide biostimulation, anti-inflammatory effect, analgesic effect with the laser? Yes. You see, you hear that you can provide biostimulation, anti-inflammatory effect, analgesic effect with the TECAR? Yes. So, the problem, one of the problems when I was inside the team, I have the players, I have the athletes, and they say, why you should you choose one or the other one? Good question, because yeah, looking on the paper, on their effect, they all do the same effect. But how you reach the top of the mountain, so the top of the mountain is your final purpose, the healing of your patient is better, that's made the difference. Sometimes you can reach the top of the mountain from one side, someone you have to take another path, you have to do another journey, because maybe one of these is more performing for the situation that I have to treat. So it doesn't mean that you have to treat all tendinopathies, all with a laser, all muscle lesion, all with diathermy, for example. You have to look for your patient, because we discuss a lot about the machines, what one parameter, the most important parameter left, the patient, because not all the patients are the same. So looking for the laser, for example, the color of the skin makes difference. Because, you know, if you go outside with the black t-shirt or a white t-shirt, you feel different heat because black absorbs more. So is one of the parameters that you have to know and to set inside the devices, because colors make difference using the laser, for example. And looking for a pathology, looking the treatment of tendinopathy, I will try to discuss about some pathologies. I know we have few times, so you are quite tired, so I don't try to get you bored and involve you much as possible. But now the problem is to make a good strategy. So, because these tools, these machines, are the tools of a therapist. So they provide helps the therapist to do something. But the problem is the knowledge and how you use that devices and the strategy that you apply. Maybe if you don't have any results, the problem is you have a bad strategy or you have bad knowledge of the devices. First of all, you have to know what you have, what you provide to your patient. As I say in the speech just 1 hour before, you have to know, for example, your laser, because not all the lasers are the same. Once you know what you provide the patient, once you know your device, you know that your device can or cannot do something. So, for example, looking for the laser, you have to look for the wavelength, for the laser, for the diathermy, you look for the frequencies. If you fail, sometimes it's due to bad strategy, not due to the devices. They are only tools. For example, I make every time this example. If I buy a brush, Italian guy that tried to reply the Capella Sistina, you know, and I paint for sure something that is disgusting and shit, I cannot say it's due to the brush. It's due to me. Michele, you're not Michelangelo. You're not good. Okay. The problem with the device is this. We buy the devices. We are able to buy the devices. We go to the patient, try to paint or try to do something with the devices. We have no results. Bad device. Maybe is not good applied. Well, once you start from that situation, we move to the pathology. So, for example, to the tendinopathies. The problem with the tendinopathies comes from where, first of all, we call tendinopathies because we describe tendinitis and tendinosis. We use only one term to say there's something wrong inside the tendons. And instead of sport and instead of all the patient, the problem is not only the pain. Because if you treat only the pain, we fail for sure. We have a big ratio of re-injury, re-suffering with the tendinopathy. Why? It's well described with the iceberg theory, the tendinopathies. What it means. You know, the iceberg has a part above the water. This is the less part of the iceberg. The bigger part of the iceberg is underneath the water, okay? So it means underneath the water, instead the tendons, our patients start to have problem and to develop micro lesion instead the tendon from long time. Above the water, that's the pain. So if you just treat the upper part of the iceberg, you treat just the pain, just the inflammation around the water, around the tendon, so the upper part of the iceberg, you fail because it doesn't solve the internal lesion of the tendon, the disorganization of the fibers of the tendon. So why we develop this problem in tendinopathies, for example? Because maybe we have athletes that do too much one movement. You see there's a lot of sides that you can develop problems. For example, our patient has a problem on the Achilles tendon because you are an athlete. Okay, gymnastics, so a lot of jump maybe. Okay. If you work with a tennis player, rotator cuff, for example. So we look for patients that do many times a movement, a drills. So around the word use could be overuse, could be misuse, could be unuse. It means in this triangle, I have to find out if my patient stress too much that tendon. I have to work on this stressing and working around the inflammation especially. If there is misuse, my concept and my strategy will be not only on solving the inflammation and the fibers of the tendon. I have to work over maybe bad movements because he has bad biomechanic, bad strategy, bad drills, for example. He doesn't have a good strategy of jumping. Maybe, I don't know. I don't. But if I don't solve the biomechanic wrong drills, I still have ratio of re-injuries or misuse. It happens also in athletes, for example. It's well described that if we go down with fitness, we have more. We are more charred instead the muscle, so we have more acid acid inside the muscles. That acid acid produce more injuries, is more aggressive on the tendon. So if our athletes, for example, get unfitted after ACL reconstruction, maybe can develop tendinopathies at the Achilles or other tendon because they at the same. For example, they try to run at 20 kilometers. They are more tired. Their muscle produce more acid, so more suffering instead the tendon. Or, for example, people over 40 years because the aging instead the tendon. You know, people can be fit until they are 50 or 60, but tendon suffers more than muscles for the aging. So they are more stiff, so we have to look for the age of the patient. Or, for example, muscle strength, women other type of features that you will look for. And the strategy, as I told you, cannot be only over the point, over the tendon. Must be over all the structure involved in it. Okay? So, I present my patient and the therapist. And we move to another point of view. Please lay down on the table. Well, once we perform a good physical examination, once we know, for example, we don't have any ultrasound or MRI to study your tendon, for example, but once we have a good strategy, once we want to involve all the structure in the treatment, not only, for example, you suffer, you ache for the Achilles tendon, for example, but correctly you say, maybe I have problem on my ankle, or I feel a reduction on the range of movement of my ankle, so that maybe could be due to the stiffness of my Achilles tendon, and I have pain, I have problem on my Achilles tendon, correct. Furthermore, you can also make or perform ultrasound to check the structure of your tendon, and you have to control both too, because maybe now you are aching from one side, but many times if you check the other one, you have some problems over there, but for the iceberg theory, you remember, you don't feel now the pain. You are under the water for the moment, but maybe from months from here, you start taking on the other side, because here you have a lot of the amount of all the micro lesion over there, and you start taking on the other side. The suggested protocol is rest, ice, stretching, a lot of therapies, but looking for the physical therapist, exercise is the engine, and we boost the effectiveness of the exercises, stretch, isometric exercises, eccentric exercise, we boost this good effectiveness with the machines, with the physical agent. Well, at this point, I have a lot of devices, but I have to think also at the time, at the moment. Looking at the timeline of every pathology, we have different situation. What I mean is still called tendinopathy, okay? Tendinopathy of the Achilles tendon. But if I meet, what's your name, sorry?
Abdurrahman.
Abdurrahman. Here, on the pain onset, and maybe is very painful situation over there. He cannot walk, he's aching, and he cannot do the stairs at this moment. I have goals and physical situation that is completely different at this point. Maybe he's ready to the return to play, so he needs something different. So it's crazy thinking that I do the same rehabilitation and I use the same devices for tension, for example, here, 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 here. My patient develop, and also my strategy and how I set the devices and the devices that I choose develops. Okay? So, at the beginning, at this point, we think about, for example, your Achilles tendon very, very aching. You cannot touch it. And sometimes, you know, you can find Achilles tendon with onion over the tendon, so great swelling around the tendon. You cannot touch it to the patient. And you want to have pain relief. You want to give immediately relaxing and get your patient stays better. But you know, from the iceberg theory, you are just working on the pain in this moment. You are not solving the disorganization of the fibers. What do you choose? The choose could be laser. I don't say every time the laser. You have to think, you have to talk, discuss about your patient. How many times you want to come to me? Laser, for example, needs a lot of visit about your patient because the photobiomodulation starts and the duration is 48 hours. Maybe if you don't meet so much the patient, you have to move to the TECAR because with the TECAR you can assess 2 treatments per week. With the laser, almost free to be effective. That's important, and you have to discuss about your patient. Maybe you want to spend all this money. In my case, for example, I treat sportsmen and professionals for the team. They come every day and I can treat them twice a day. So I don't have this type of problem. Every patient requires to be involved in the discussion and the decision making. And also you have to know what you can provide with your devices. Well, now at this point, another complication. If you work with laser, with the diathermy, you know you work around a tendon in that case. Or for example, if you have a sprained ankle, you have a lot of swelling around a sprained ankle, okay? Before, someone put the question about the lymphatic, okay? We always suggest to involve the lymphatic system instead the stimulation. What I mean, if you have pain on the tendon, you don't have to focus and treat only the tendon. It's only local treatment, so you disperse part of effectiveness of a global treatment. So I make this example. If you agree with me, if you have swelling around a sprained ankle, what's the problem? You sprain and have a lesion on the ligament, but you have a lot of swelling around the articulation, right? So you have the reduction of movement due to the liquid, okay? If you just treat the ankle and move these liquids, you still have maybe congestion on the lymphatic system above, okay? It's like when you have a car accident and you have a lot of traffic below the accident, okay? If you just stimulate the liquid over there, here you find congestion and the liquids come back. So if you open the lymphatic system, you treat the lymphatic system before treating the sprained ankle, the swelling, you have better drainage, right? Well, for all pathology, we have swelling. For example, around his tendon, their swelling is not so big like in a sprained ankle, but we have still swelling around this tendon. So if we open the lymphatic system before going to his tendon, we get more results doing the same stimulation over the tendon. I do the same stimulation over the tendon, but before I open the lymphatic station, my patient refers better. Not immediately, but the day after he says, comparing the first session and the second session, when you involve the lymphatic, I stay better. And we see along the experience and using this approach, this global approach. And looking for example, using lasers. Doctor said, remember, you have liquids, you have water that absorbs part of light beam. If you have swelling around the tendon, if you have liquids, that liquids absorbs part of your light beam. So the more you remove liquids, the more you use also maybe cryotherapy or something to reduce the liquid around all the structure that you want to stimulate, more effectiveness of the laser, for example. Well, now the suggestion is, if you find on this timeline, on tendinopathies, and Achilles tendon that is really aching, very painful, at this point, the best therapy to make biostimulation and pain relief could be laser therapy. Because, as you see with doctor, we discuss with the radiofrequency, with the TECAR, vascularization, biostimulation, but if it's really inflamed, really painful, giving too much heat could be harmful. So, looking for the laser, you can control the wavelength, you can control the modality of the emission, you have a thermal control also inside this one. So, with the laser, you can give the proper dose for a really inflamed tendon without risk to have pain rebound the day after. So, looking for choosing devices, at this point, I say, I choose laser because for my purpose and for your situation on the timeline, I think this one is more performing. While you stay better and you move on the line at this point, I will choose maybe the TECAR because I want to assess also exercises and make and work over the elasticization of your tendon, then TECAR could be more performing at this point. But at the beginning, so you can see the difference using devices, we start from laser. That's why if I go directly and show to you, okay, use the laser like this, okay, the Italian guys say this, and you understand why. This is to involve to you on the decision making and how to develop a strategy. All depends on the strategy. Bad strategies could lead to failure and thinking machine doesn't work. The more you think, the more therapists are involved in this. Also in Italy, we have this problem. A lot of therapy thinks that using physical devices is B class of treatment. The real therapists use hands and manual therapy. If you use devices, you are just like monkey doing this. How are you? Fine? Oh, me too. Like this. No. The more you think about what you are doing with the physical devices, as I told you, you put the booster over something that is still good. And you do also something more. Please come, therapist. Well, left or right, sorry? Left or right? Right, okay. On this side. Well, as I told you, to open the lymphatic system, we have to treat the lymphatic station involved in this on his problem. And in that case, we treat the Achilles tendon. We can open the lymphatic station here on the groin and the lymphatic station on the popliteal fossa, for example. In order to don't uncover you, we just move directly on the popliteal fossa and we skip the part of the lymphatic of the groin. On your stomach, please. So maybe I open the lymphatic station of the groin, maybe also here in the abdomen, could be useful. Then I move and I feel, if you touch here, but try to touch here and here. You feel something different? What do you feel?
Here's harder.
Why?
Lymph accumulation.
Maybe, could be. Thank you. Just because I'm not joking and you feel something different. Here and here on the right, he have something that doesn't work, but it doesn't refer anything over there. But if he's an athlete, he uses a lot his legs. These legs suffers more because maybe you suffer from this reduction of movement of your ankle and you make a lot of compensation. And also you're not able to make a good drainage of this structure. So here he felt another sensation. Here you have this congestion. So if I treat the tendon directly and then I don't remove this congestion, I still something miss. Okay? So in order to open the lymphatic system, we can use the TECAR, but now we are using the laser. We open the lymphatic with the laser. Both two are good to open the lymphatic. Well, thank you. The applicator. Well, I set the laser and I move close to you in order to work. You are quite far, you don't see the interface, but you can do a lot of things with this device and you are skilled in it. You can go and manage what you want, choosing wavelengths, power, what you prefer. If you treat your patient starting from protocols, protocols provides to you information and guide to you to make the correct output, because how many watts, how many wavelengths I have to use. The pulsing or continuous mode of my laser, how I can set it. You are guided by the information and the algorithm set inside all the protocols. So, for example, Achilles tendinopathy, the machine wants to know about your patient, the last part that we don't speak about. Is that the situation acute, subacute, chronic? Regard on the timeline. Why? Because acute required less energy. If it's chronic, more power, no problem. Because we want to make vascularization, not only anti-inflammatory effect. Now about my patient. You remember the age of my patient makes difference. Wants to know your patient is below 30 or is old person, because more stiff tissue in old person. I think it's young. The somatotype of my patient, because also fat make a difference. Fat person, lot of fat around, can absorb part of my light beam. Is good, is meso, perfect. And at the end, not only, the color of my patient. If I treat a patient with white skin, absorb less light, black a lot. So I have to work, for example, on the modality of emission, not in a continuous, quite pulsing, for example. Or typical, when I was instead the team, football players, everyone has tattoo. So you pass from white to the black of the image of the tattoo, okay? So machine has to know you have black and you switch the button on tattoo because more sensitive, instead the machine knows that have to provide less energy once you are on the black. And the end, the pain referred by the patient. Less pain on the VAS, the referred pain of the patient. 1, more energy. Very painful, for example, we are talking about the onset of tendinopathy, really, really painful, so maybe 10. The final output will be lower. So the protocol suggested looks for the opening the lymphatic, and after, looking to treat directly the tendon, and then the fourth step is to treat the muscle connected to the tendon, because the tendons are the ring of junction in the chain bone and muscle. The connection is the tendon, okay? If we have suffering instead the tendon, especially on this side, maybe we have stiffness and problem on the fascia and on the calf. So if we loosen the tension of the calf, for example, could be useful to reduce the pain referred instead the tendon, okay? So that's an example of global approach. Opening the lymphatic first, treatment of the tendon because it's aching, and treatment of the muscle, okay? And then maybe assessed exercises, isometric or eccentric exercise as well, because as I told you, the focus and the engine is still the exercise, okay? Well, now we are ready to work. We have to put on the glasses. You, me, and the patient. You are quite far, so it's not dangerous for you. Thank you, patient. Take it. Okay. Well, I show you at the beginning, then you reply. One parameter left before starting. The area. When you work with the laser, you know you treat working joule per centimeter square, right? Okay. Now, for the features that we set, joules per centimeter square means in the acute, I have to give lower joule because the tissue is very inflamed, required less energy, so less joule per centimeter square. The more it's chronic, the more you can give more joules per centimeter square. It means every square, every centimeter of his skin is 1 centimeter square. 1, 1, 1, 1. And maybe we can give 5 centimeters square here, 5, 10, 15, 20. Okay. In the past, with old machines, you have to calculate by yourself. Now we have computer, we have the phones, the mobile phones is so useful, touch screen, so useful, the algorithm. This technology is coming also in rehabilitation and useful also for us. And for example, I want to set the area of my tendon. Okay, this is the length of my tendon that I want to stimulate. Perfect. Go inside on the device. This is the length. Voila. This is the width of the tendon. Okay, I set inside. I don't have to calculate. Machine provides this to me. As well, I can do it for the dimension of the muscle that I'm going to treat. This is the wide. The form is close to triangle than a square. So, for example, it's quite wide, so I can arrange it looking for this, 20 centimeters per 8. This is the two area that I set. Now I'm ready to work. Well, ready to work, better if you work, I will use the microphone, thank you. Better if you work on this position, maybe on the patient when you treat the tendon. While you open the lymphatic, stay with your patient more relaxed. So, put the tension and add the tension on the skin, so you reduce the bumping of the skin. You remember, the more you have the more structure you have between your final target and the skin, the more you disperse energy with the laser. So the more you reduce this adding quite tension, you reach better results. Okay? And here you have the stimulation with the laser over this area to open this lymphatic station. Okay? Try by yourself. From this side is better. From here. Okay. Over there. Add the tension and try. Move. Is like drawing, for the example of Michelangelo. You have to feel, come on, stay. Okay, remove the finger and stay and move. Your patient will feel quite warm over there. Can you give us the glasses to him, please? Are you okay, patient? Quite warm? Yes, okay. We stimulate the lymphatic ganglion on the popliteal fossa. Okay. With the laser, you have to be orthogonal, remember, because if you make inclination, you disperse part of a light beam because you have a reflection of the light beam. So stay orthogonal with the laser. Go on, no problem. You don't burn him because you have also a thermal control inside the device. So we are sure to work instead 2 thresholds. For the research, opening the lymphatic station required almost 41, 42 degrees. Once you reach this temperature, you open the lymphatic stations. If you exceed this temperature, you make congestion because too much liquid coming. If you go and make cryo, for example, over there, you make congestion of the lymphagen, so you have spasm of the lymphatic system. So lower congestion, too much congestion as well. Spasm, too much congestion. Thank you. Well, now you perform an opening of the lymphatic. After, you move to the stimulation of the tendon. You skip the protocol and you move to the stimulation of the tendon for the parameter that you said before. Now, what we have to know, because it's essential when you treat with the laser. Everything, every point. They support you. I see you. Good therapist. Well, for example, now we have the Achilles tendon, and the Achilles tendon is immediately underneath the skin, and nothing is between the transmitter to the tissue. Okay, but maybe if you want to stimulate the meniscus, if you want to stimulate the supraspinatus tendon, you have other structure, for example, bones that reflects your light beam. So in order to be more effective, you have to think about the anatomy of the structure that you are going to stimulate. So, for example, here on the tendon, good idea is to stretch the tendon, because if you work with the tendon like this, you see the fibers collapse. So you make over the skin the stimulation, so you reduce the surface of the tendon in contact with the light beam. So add stress, add tension, and also remember the tendon is not flat. Here, for example, you go over the muscle, it is a flat surface. The tendon is round, so you have to move, and follow the form of the tendon, because if you just do this, you stimulate only this side of the tendon and you lose the other part of the tendon because it's quite close to a cylinder. Okay? Okay. Can you give your glasses to him, because you don't see the light beam? Thank you. Well, let's go. Try. We try to do this, and as doctor asked, we want to involve you using the devices, because once you stay comfortable on the seat, everything is clear and everything is easy. This is only theory. The more you move on the patient, the more you have to do something, and you see it's not so easy, right? Stay in contact, because if you stay far, you disperse part of the light beam because you are far. For the machine, this applicator means you are at this distance. It's used by the machine for knowing the distance that you work. Okay, and for making the proper dose, you have to fill in the same way all the parts of the rectangle that you set. If you set, for example, 3 centimeter, 4 centimeter per 10, you have to fill all this area in the same way. So maybe you follow the fibers of the tendon, could be a good idea, but use the same speed and follow and cover all the rectangle. If you cover just one side, change the final dose, because here you give all the energy, so it doesn't mean you are giving 5 joules per centimeter square. If you stay just on this side and not the other side, you are giving 10 joules per centimeter square, because your way to provide it is changed. You set, and for the machine you are doing something, but in the real we are doing different, so you give a different dose. So maybe you find different results, depends on the skills on the therapist. Okay? Stop, thank you. Last point is the treatment of the muscle. Okay. Are you okay? Okay. One moment. At this point, we can add something to the laser. So, we can add the mechanical action of this tool, okay? So, with the laser, we understand that you can provide energy, because laser produce ATP. We can produce vascularization, because with the laser, we can produce nitric oxide, vascularization made by a chemical, okay? We increase the temperature, and also this provide vascularization, and also we provide ROS, related species of oxygen, okay? But using this applicator, the smaller and the wider, you just use the chemical interaction with the laser, because you don't have any physical interaction with your patient. It's just light, and you don't feel the light. I have the light over my face now, but I don't feel the sensation of the light, and I don't have any mechanical action over my body. To make the effect of loosening of his muscle, because it's stiff. Oh, there is. Please come. Touch here. It's quite stiff or not?
Yes.
Okay. You agree with me? Well, if you want to obtain this loosening, you can have only with the chemical, so only with the light, and adding a mechanical action. For example, you are a manual therapist and you do deep transversal massage, for example, you work on the fibers in transversal way, because the direction of the fibers is in this side, like this, and I go transversal. I make this biostimulation over his muscle, and I can also ask for, please come a little bit down, please, down. Thank you. And now I can also make something physical over him and ask, for example, please move your foot up and down. The exercise that I told you. So this provides also more oxygen to his muscles, and slower, you do it but slower, thank you. And also you disperse part of the heat that you are providing. This application provides heat. If you don't want to burn the patient and make better oxygenation, if you add movement, you disperse with the movement part of the heat, so is more comfortable for your patients, for example. It's been painful? Okay, relax. Do you feel some heat? Just a little. Okay. Remember, the situation is, for an acute situation, my patient is maybe old lady, scared to be and to feel pain. Okay, this is smooth application is. How do you feel? Are you okay? Here you feel on the muscle now. You feel something? No. Okay. No. So the application now is for his muscle and to loosen it. Well, thank you. Yes.
By using this method 2 application,
Yes.
the laser is fixed on point, not movable.
Oh, you can move it. You can move it if you want.
But now,
Depends on your choice.
while we use now, we
Yes.
fix it for some second.
Yes.
But we know about the high power laser, we must to be moved
Yes.
all time while we application.
Yes. Yes. This type of application. So this theory that you say is when you use the laser using the common applicator, and it's good. Once you want to get more from your laser, we develop this applicator is close to an action with the TECAR. But in that case, we provide no electricity, but laser, so light force, over the surface. So we make this mechanical action of the patient, and remembering, I set an area, I inspect this area, but I stay over the point for a little while to make it loosen. Okay, I obtain this mechanical and in loosening while I ask for movements or I move myself. If I just do like this, okay, maybe it's more performing the TECAR in that case, or using the common applicator, not using this one. This one is when you get more skilled. I want to show you, and I know now you have to move to the theory to the practical. We see using this, better ask for movements and better ask and try to move yourself like this, not do this, okay? Because we want to work over the fascia and want to make and regain a good loosening and orientation of the fiber of the fascia and also the muscle inside.
I understand why you use another applicator, but I ask about the risk of maintenance.
Yes.
The laser on this point.
Okay, if you stay, you risk to burn the patient. Yes, yes, you don't have to stay too much. So for the common applicator, you have the thermal sensor, so you don't burn the patient, because the machine recognizes the temperature, and like when you have traction control in your car, if you push on the accelerator and is in wet condition, you don't have wheel spinning, okay? If you don't have traction control like a sports car, you risk to crash, okay, as well. If you have these applicators, especially, you are safe and you are not worried about to burn the patient because the machines control it for you. Once you have this device, you don't have the thermal, so the traction control is the hand and the ability of the therapist. So once you move to this, you have to be more careful, ask more to the patient. Is it too much heat? How do you feel? Because you want to treat him, not to burn it. You're welcome. Okay, so. Okay. Well, now, if you want to move and see other application, thank you, and look for the diathermy, for example, for the same purpose, so for the same pathology, and moving on the timeline, we move now to the diathermy, to the TECAR therapy. As the doctor said, the problem at the beginning is find out the geometry and the application. So we can apply the common plate in one point, and also we can decide by the frequency and the way to treat it. Well, we have different type of applicator. We have adhesive applicator. Now the glass is no more required. And we have to think the path of the electrons that we want to do, okay? For example, with this tendon, and we want to make the biostimulation, we want to make the path of the electrons from this side to this side, we can put the common plate under the type over there. So we have the flow of the electrons from here to here. I don't need to go on his back because I dispersed part of the energy moving here. I just keep the common plate under here. Or if I want to get and reach more superficial effect with the adhesive plate, I can put the plate over there. If you remember, when you work with the TECAR, you close a circuit. So you have a flow of the electrons from the transmitter to the common, okay? So the electrical arc will be from here to here if I close like this. But if I put this one over there, I lose the ability to do something also over the muscle if I want, because I find here the electron and I'm too close to the electrode. If I want to stimulate only the tendon, could be a solution. If I want to stimulate also the muscle, no sense go so far. We put the common plate under the thigh. Okay? So, thank you. We add some cream over the plate.
Any cream active on blade?
Sorry?
Any cream can use on blade or special?
Yeah, we suggest the specific cream of diathermy because it's well-studied cream to make hydratation over the skin, but also you reduce inflammation and provides better, good conductivity. So not all the cream is good. We see that using good cream create better effect, and with the TECAR you have to be careful. You can also risk to burn the patient and feel something discomfortable for your patient. The more you use the correct cream, is more sweet for your patient, is more good for him and for the final results, because you have better conduction. Remember, you are using electrotherapy. So especially when you have hairy person, the problem is to point effect. So here on the plate, sorry, thank you. Here on the plate, if you don't keep the correct contact and you have a lot of hair, you risk to have stabs because the electrons flows on the hair and not on the skin, so it's burning, it's uncomfortable. So more using cream to create a film between the transmitter and the skin of your patient, and you don't risk anything, okay? Especially the old models of TECAR provide all the energy once you touch, so it's very easy to have this comfortable sensation when you touch and when you remove. Now the device is developing, we have more technology, so they add with the traction control energy but smoother. So it's more comfortable for the patient, and the therapist is not so scared to, I don't want to burn my patient, okay? Well, we have to choose now the applicator. For the tendon, for example, that is so small area, this could be too much big, because the problem is still the same. I am here, but once I reach the tendon, you see, only this part is in contact. The other two is outside. So here I risk to have all the energy, and here could burn the patient, okay? So looking for the position, the area, and the size of your patient, you look for the correct position of the common plate and the applicator. This one is round, you see? This one is flat, this one is quite round. So I can fit more over my patient. And at that point, you remember, you use the laser with the glasses and you stretch him. Now you can ask, for example, for movements. Is it painful? Ankle movement, is it painful? Okay, because you felt pain when you stretch too much, right? Okay. Maybe you have also problem on the bone over there, not only on the tendon, because maybe you have conflict with the, sorry? Yes, in this side, yeah, because here you feel pain, slight, but you feel more pain when I do this. If the structure responsible of this pain was only the tendon, you have to feel pain here and less here. If you feel in that position, the tendon is impingement. So maybe he felt referred posterior pain, and you think is the tendon, but the bone is underneath and refers also over there. So maybe, yes, you have the stiffness, but who's the responsible of your pain? The tendon or the bone underneath? Could be. So that's why, for example, with this device, you have more than one frequency, because we know from all the speech that you hear, structure poor of water are resistive. So in order to stimulate that type of structure, we need a lower frequency. If we have instead 448, the common resistive frequency could be useful for the tendon. I have a problem on the bones. More resistive structure instead in face of tendons, I can stimulate also the bone, for example. So looking on the strategy, we don't make an assessment at the beginning, but looking for your pain and what you say, maybe using this type of frequency to make the simulation over the purpose and over the structure that really aching, and is maybe not only the tendon but also the bone. Okay, I can ask, for example, eccentric exercise or just staying and work like this. Depends on your patient. If he felt pain doing too much movement, don't move. Just say, you have this comfortable position, you look to your patient, you talk to your patient, are you okay? And you just work, okay? Well, now I set the device for you. I start doing, and then you do by myself. This is the swing mode. It means inside you can have more than one frequency. So I don't have to come here and change every time the frequency because I want to say, I want to go on the tendon, I want to go on the bone and change every time. I'm worried, I'm focused on my patient, not on the machine. So I will go from the lower frequency that I have, that is 300 kilohertz, to, for example, 500 kilohertz, the free more resistive frequency that I have, because if I go on 750 is the capacitive frequency, okay? I can use the continuous mode of the laser, so the heat is really high, or I can ask for the machine to make pulsing, so the electricity has 50% working, 50% stop, less heat, or another mode called dimmer mode. It means you have the machine working for a little while, and once she go lower, it's not zero, but it's almost 30% working, so it means mild heat. Okay, in continuous, you're giving a lot of heat. In that case, I prefer using this situation. Mild heat, but not too much, in order to don't rise up too much the temperature of my patient. Once I set the temperature, and I set the watts, 15 is enough, I'm ready to work. Put on the cream on the patient. And once you are ready, you can try and make your stimulation. You hear? Now, once I touch the patient, the machine is working. If I remove, stop. Okay? So now I'm no more worried about the machine. The machine will provide energy and change the frequency. Click. When you hear this noise, click. The machine will change the frequency because I set 8 seconds per every frequency.
The sound will change frequency from...
Now, this sound, that buzzer that you hear, is the biofeedback. So it means the charge that go from this side. Instead, it means we have lot of resistance instead my tendon. The more you feel beep, 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 the more you feel, the more you have flow. So this biofeedback provides to you, this noise provides to you the information, you have a great flow or less, okay? The more, maybe, we start now and we have this noise. After 10 minutes, maybe, I hear more beep, beep, beep. It means now my tendons allowed more the flowing. So I'm making a vascularization inside. I reduce the impedance of the tendon. So it means something happened inside his tendon.
This change can be measured numerically?
You can do manual or you can do automatical. The swing mode is, as I told you, the automatic gear. If you want to change by yourself every frequency, maybe you want to go 10 minutes at one frequency, 10 minutes on another frequency, you do by yourself, as you prefer. Okay, so you see, sorry Jacques, can you show the animation of the tissue? Ricordi come far vedere le animazioni? Allora, swing, no, aspetta, rimani sullo swing, dai play, no, vai dai play, fai lo scroll da un lato. Okay, okay. In this animation, for example, you see an example of the tissue that you are stimulating. So it's good for the therapist who looks for the machine, what I'm stimulating. You see an animation, you see looking for the frequency, the structure that could be more stimulated by my action, okay? For example, now I'm going to stimulate, I'm providing 300 kilohertz. After 8 seconds, I hear the noise, click, 448, okay? And you see the bone and also the structure around the bone. Click, 500, you see a lot of structure around the bone, okay? So this animation could be useful for you for remember what I'm stimulating, okay? Are you okay? Do you feel quite warm? Just a little, right? Because you have to stimulate, you don't have to do the ironing over your patient. Okay, you want to try? Please.
Should I move his leg?
If you want. If you don't want, you don't move. No worry. Okay. When you get the contact, machine is working. Okay? I know I cannot solve your problem right now doing a demonstration, just to explain, and you are useful for us to discuss a lot about you have a problem over the tendon, but it's really the tendon. All this information, all this question provides to you maybe the correct assessment, and is the difference of failure of good treatment. Okay? Well, for example, now he's providing the treatment with the common applicator. But if I feel a lot of stiffness around the tendon, if I feel that I have to do something more, and you are a therapist skilled using these blades and a lot of technique, you know, maybe Graston technique or Ergon technique, there are a lot of companies that suggest this myofascial application without the TECAR. If you add the action of the blade with the vascularization that you provide and the biostimulation that you provide with the TECAR therapy, is the concept of the booster that I explained to you. You add more mechanical action with that blade to the biostimulation that you have with the TECAR therapy.
But why do you use the biostimulation? Not all item contact is a patient.
No, only the part of the item in contact on your patient. Okay, so now you don't have the gloves. We suggest that the therapist must wear gloves. So you don't touch it, you don't have part of the energy on your body. Okay, and the tool is set in order to don't burn the patient on the side, on the edge of the blade. So when the machine recognizes that you put the connector of the blade, you have a smoother application of the energy, so you don't risk to burn the patient because you have all on the edge. This energy is dispersed on the surface, is quite rounded. It's not like a knife, so you don't cut the patient at all, but you have more this mechanical action over your patient, so you have this combination of effect. You see here, and then with the laser, once you believe in one effect, once you believe in one technology, you can ask for something more and mix effectiveness from other technique, manual technique in that case. So is the sense is in physiotherapy, manual therapy, physical medical devices and physical agent are on the same side. There are no therapists who work with the machine and manual. All this together, because the final purpose is reach the top of the mountain. How you get there is by your decision, because you are a professional and you decide by yourself, not looking, okay, I see a paper, 10 session of laser, and you see after, and go. This is the way that you have some patient happy, and some patient, I don't like it all, I don't have any effect. Because maybe along the treatment you don't have time to discuss with your patient and discover, for example, in that case, but I feel that difference, and you underline that something is not only on the tendon. Are you okay? Stop. Thank you. Well, this is an example of using the diathermy applied with the same pathology, and we use, for example, the laser on the same pathology, looking for the final effect and looking for how they work for the physical agent that you provide. It's only an example, looking for tendinopathies. And the same approach we have on neuropathies, the same approach we have on muscle lesion, we have on gonarthrosis. You have to think what I'm treating and how my action can help that situation. Thank you. Now, because I have him and we can discuss more. Thank you. For example, you can see another application of the diathermy, of the TECAR therapy, is called automatic mode. Okay? Maybe you see in other ways, and we can discuss how diathermy that biostimulation provided with the TECAR could be useful for an athlete, could be useful for a patient. Now, we don't discuss more about your tendon, sorry. We discuss a pathology that you don't have, maybe, that you maybe have a lesion on the quadriceps, for example. Okay, so please sit down on the table. Inside the muscular lesion, we have a lot of troubles. And if we have, for example, patients that still refer problem on the quadriceps, still stiff on the quadriceps, maybe, we don't have to think and to treat only the quadriceps. Sometimes the problems comes from an imbalance on muscles on the other side, on the antagonist muscles, for example. If you are a football player, sorry, and you have to do a lot of this, the movement of kicking, and you still feel the sensation of stiffness, no pain like stabbing pain, the typical pain referred by a structural lesion of the muscle, but you still have trouble, you still have pain instead the muscle, and you have stiffness inside. Maybe it's due that you have an imbalance with your hamstring are too stiff, and you don't have a correct mutual innervation, quadriceps and hamstring. So while you kick, you need that your hamstring, while you make a contraction over there, they reduce their contraction, so they have this mutual innervation and relaxation of hamstring while you contract the quadriceps, for example. If you want to work over this situation, so now is no more biostimulation to make something like anti-inflammatory effect, analgesic effect, is to use an electrical information to support kinetic control, for example. This is exercise connected to regain good muscle control. So in order to, sometimes when you have some problems, we don't feel a structure. In order to feel better structure, we add the action of the diathermy over the structure that I want to stimulate. I show you. Now, my colleague, thank you, Jar, put on these electrodes. Diathermy is not like complex muscle contraction. You don't provide electricity to create muscle contraction because it's not the same energy, it's not the same frequency. We use that energy. Sorry, can you?
This leg, please.
Okay, thank you. Please come closer. Sì, grazie. Okay. For example, electrode 1 on the quadriceps because he felt problem on the quadriceps. Electrode 2 on the other side on the hamstring. Okay? Thank you. You have, with this device, you can manage 3 electrodes maximum. In that case, with mutual control, so one side and the other side, I don't use the third. I have also, thank you. These adhesive plates, so I'm not worried about where I have to put it because with the metal I cannot fix. With the adhesive you can fix on the back, as the doctor said. Sorry. So I fix the common plate on his back. So I'm ready to work. Now the therapist is no more necessary, and I can give this button to the patient, panic button. If you feel something wrong, push the button. So you don't burn the patient. If the patient says something is wrong, immediately you stop the treatment. Well, now for sure the stimulation will be resistive. No capacitive, no sense in this. We want to be resistive, we want to stimulate the muscle, the motor control of the muscles, their sense using resistive frequencies. And looking for the application, machines know that I put the electrode inside. Now I move to the automatic mode.
The machine automatically recognizes the electrode.
Yes, machine recognizes that I put the electrodes. Here you see the electrode, and I say to the machine, do you have 3, 1, or 2? I have 2. What do you want to do? Sequential, so first the electrode 1, then the second, or all together working. You can choose. In that case, you work all together, or sequential, for example. How many seconds? For example, for the quadriceps, I want for the quadriceps 8 seconds of contraction because I'm working on the quadriceps. For the hamstring, less. I just want 6 seconds, as you prefer. As you see, you can change everything inside the parameter. I set the temperature. I have to set the modality of emission, for example. I don't want the swing, I just need the resistive. And I just want to say, dimmer mode could be or continuous if my patient like it. So use continuous. If you feel too much heat, you just say to me, I slow down or switch off, okay? Yes, here's the button. Now I'm ready to work. Now I ask to my patient, please feel the stimulation and follow with your contraction. When you feel heat over the quadriceps, move the quadriceps. When you feel heat on the hamstring, move the hamstring, okay? If you don't feel the heat, just tell me, I raise up the temperature, I raise up the energy. Okay, machine is working. When you feel the heat on the quadriceps, now the therapist knows the electrode is working because I can see keep on the quadricep. Now you have on the go, no, go below with the, okay, stay, go. Wait, now this switch off. Okay, so one, okay, no worry, okay, come back. Okay, one, so contraction of the quadriceps. Keep for 8 seconds. Go. Okay, so you follow the machine. Now the therapist could be involved in that decision, control the machine, or also provide manual resistance, for example. Thank you. Keep. Okay, you feel burn? Okay, we can go down. In that case, too much energy, we can assess it. So, maybe using the dimmer mode, the pulsing, and lower energy. Just 10, okay? Keep, down. Keep. Rise up. Okay. One. Now, no more, less heat. Okay. Keep, down.
This is just the feedback by heat.
The heat, yeah, the feedback, you don't want to burn the patient, for sure. The heat in that case is vascularization. And move while I'm talking, keep moving. Now, the heat is a feedback for the patient to recognize a stimulation and follow a contraction in that case. Now I can ask to follow the contraction, or while he performing this movement, I can ask, for example, for eccentric exercise. Now I make a resistance for a concentric movement. Maybe I can work in opposite way.
I ask, is this just a heat to recognize to patient how to move on flexion and extension?
Yes, the heat is what you produce inside. So the patient feels it, feels something over the muscle, feels this sensation, because as I told you, it's not a current to create a muscle contraction. If you want to create muscle contraction, use complex.
Yeah.
If you want to regain, for example, very low muscle after ACL injury, you have to use the electricity of complex, for example, because this is for muscle contraction and muscle regain of strength. In that case, is to use the diathermy for motor control, so it's no more for create a contraction in him. So the heat is a sensation to feel one side. He has to feel the side of quadricep, he has to feel the side of the hamstring. And also the vascularization, that heat they provide, also allowed more vascularization, more activation of this structure without tricking the brain, without the help of electricity. You know, the electrostimulation is artificial. So you are not stimulating the muscle by yourself. You help the brain contraction with adding this type of current. In that case, we use the current to giving informations. Okay, is, as I told you, another way to look at one physical agent. You have the same therapy. You have this.
Like biofeedback with electrotherapy.
Yes.
If you
Okay, you did it. Yes.
We use it like biofeedback.
Yes, it's the way to see it. It's like a biofeedback. For example, the inner applicator for vagina, for example, is also to provide vascularization, loosen of the tension of the muscle of the pelvic floor, but also to provide biofeedback, because the lady has to feel, maybe if is the pain you refer to an spasm, you have to
can recognize how to release.
Yes. If he's because he's weak, you have to recognize the contraction of the pelvic floor. It's not so easy to recognize that structure and make contraction. So if the patient has no problem, no worry. But sometimes some problems comes because the patient doesn't feel a structure. Some patient, for example, doesn't feel, especially lady, for iliotibial syndrome, has valgus of their knee, so they start aching because maybe they like run, and they develop problem on the iliotibial tract, and they have problem on this side. if you go with the TECAR, with the laser only over there, and you don't solve the valgus stress because the weakness of the muscle of the gluteal muscle, the little and the medius gluteal muscle, you still have this valgus stress, still have problem. The patient say, I feel better once I make the therapy because you make vascularization, analgesic effect. I start running, pain again, because you remember, use, misuse, unuse. This is a misuse of the knee. You don't correct a problem of the valgus stress of the knee, still have problem. Maybe you can use if you want, if you don't want, if you prefer. I prefer just my technique and in my gym, not too much electrodes and exercise, as you prefer. But if you want to add this stimulation because this guy, this lady doesn't recognize his gluteal because someone still, for example, you assessed a Bulgarian squat, they still do this. My knee is over there. Yes, but you lose here. Contract the gluteal. I don't feel it. I still feel the quadricep working, but here not. And that is the problem. They cannot do this. They cannot control. And this is correct do. This is incorrect. Yeah, I feel the quadriceps working. No, over there, no working. So you still have a problem on the knee. Okay? So other way to see a problem. In this case, for example, iliotibial syndrome is the graveyard of physical devices because a lot of failures. Therapists still stimulate this area and say, I treat my patient, he have pain. They don't work. Yes, they don't work because you don't solve the real problem, the valgus stress of the knee. You don't solve the weakness of this muscle, and the weakness is solved by exercise with the strengthening. You cannot strengthen the muscle just putting some electrodes. The electrodes is just to feel more structure. Okay, I don't want to create mistake. I do not say with the TECAR you get strengthened on the muscle. You feel more in order to get the strengthen, but the strengthen is obtained by your patient because he recognizes you give more information to the brain of your patient. So the more the brain feels a structure, the more the brain can control. So we are talking about motor control now, not more biostimulation. Is another side. We use a physical agent and we bend this physical agent to our purpose. We are not taken by hand by the physical agent. Okay, do what I want. No, I am the therapist, the physical agent. I use the physical agent as I want for my purpose. So you see a lot of protocols. Protocols are set by research, by evidence, but you treat your patient, so you put your face on your patient. So if you don't any results, patient doesn't look at the machine, look at you. So do what you believe. If you think for your patient, this is good, this could be a good strategy, follow that situation. Don't apply 10 sessions at the same way, at the same power, because everyone do like this, because it's the best way to fail and the best way to think B class of treating. The real therapy is manual therapy exercises. Okay? Thank you, and thank you for your patience. Well, come facciamo già? Come siamo? Sì? Ok. Thank you. Well, if you have any question, if you have any doubt, just tell me. And if you want, we can move and discuss about, for example, neuropathies, as you prefer. We have time, so we can discuss a lot about this. Do I say something you don't agree, something you don't understand? Do you have any questions? Okay. Well, if you want, I can discuss about neuropathies. That could be a good and interesting field. Well, with neuropathies, we have different ways to apply the physical agent. And still have the problem, I use the diathermy, the TECAR, or the laser. for your opinion now after quite discussing. What do you think? What will you choose, for example?
According to patient needs,
Mm-hmm.
according to pathology,
Yes.
we have with my patient, I detect the best for him is laser or another physical agent.
Perfect. For example, if you meet a patient with a real painful situation, with the sciatic pain going inside the practice like this, and maybe say, this morning I was good, I do this, I cannot walk anymore. You will provide a therapy that works with heat or with the laser? Okay, you understand? Yes, because in the past in Italy we have this problem. We find the diathermy, the TECAR therapy, and we applied on everything. But we found the negative effect of the heat, especially with the acute. With the athletes, for example, we applied every time the diathermy on muscle lesions, especially in the acute. We don't control the temperature because we cannot. And this crazy thinking, sometimes in the past, some companies say, I use the diathermy in a thermic way. So you are using a therapy called diathermy. That means in Greek, heat through in athermy. Heat through, no thermy. No sense, because this flow of electrons provides some heat inside, and you cannot control it, because the feeling of the heat depends on the patient, on his sensation. So it's a subjective parameter, okay? Sometimes when I treat patients from cervical pain and dorsal pain, I have this situation with the diathermy. They feel heat, you feel the heat using the diathermy, right? Okay, imagine I'm treating your back. You have a compression of the dorsal root of the nerve of the dorsal tract, for example. Patient says, here I feel heat, heat, he's cold. Then heat, 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 cold. But the machine is still working in the same way. What's the problem? You have a compression, you have a suffering of the dorsal root of the nerve, so the patient says, it's cold. What do? You raise up the temperature? Fail. Because in that case, the feeling of the heat is subjective, is not objective. With the laser, for example, you have a sensor that reads the temperature of the skin is 38, is objective. So you can control more, you can manage better the acute, because some patients like warm, so they say, no, it's good, it's good. Some patient doesn't like the warm, but in the acute, you risk to give too much for the sciatic, risk to giving too much heat. Day after, pain rebound, your patient stay worse and worse. Well, can you stay with me and be my patient just for a while? Okay. With the laser, so the application of the laser on neuropathies required talking more on the anatomical doors. What I mean? Please, lie on your stomach, please. I don't switch on the laser, but discuss. Yes, yes, perfect. We discuss about neuropathies, we discuss about physiotherapy. You see, same, the concept of timeline, and still we have the problem of the anatomical door. If you have the patient that suffers from sciatic pain, and you put the patient in that position, what's the problem? We see, with the laser we have to assess the power, the wavelengths, all that features, but we still have also the bones and other structure that can absorb or reflect part of our light beam. So if I have my patient, in that position, I have the spine in an extended position. So the posterior spinal process covers the disc and the root of the nerve, okay? If I want to make the best stimulation over the root, I have to change the position of my patient. So better adding flexion, because if you add flexion to the spine, you open the spinal process. And if you add lateral and rotation to the spine, you expose better the root of the nerve, the sciatic nerve, depends The sciatic nerve, we know we have more than one root, okay, that produce and create the sciatic nerve. Maybe we want to stimulate more than one root. We find by the manual skills the process of L4. You know, the process of L4, you find out the conjunction of the two iliac bone, okay? The line that of conjunction of the iliac bone is the process of L4, okay? So I put the patient, so I move the microphone on this side to me. To me. Look to me on this side. This side. Okay. Well, I add flexion to my patient. So here, conjunction, L4, okay? In this space, I found the space between L4 and L3. Here I have just flexion and could be enough, because remember, in that situation, my patient suffers more. Maybe my patient doesn't like that position. I treat my patient in a flexed position, in a seated position.
Devi usarlo per forza.
Like this. No, no.
Sì, sì.
Okay,
Se no
sorry.
non si sente.
Sorry. I treat my patient on a stair, so for example, like this, or on a sofa as you prefer, and like this to add flexion. If your patient can stay, on the table and you can add this flexion, better, okay? If your patient can move also, adding rotation at the inclination, you do this. This is common in manual therapy. You add flexion and side bending is called. So also in osteopathy, you assess this technique, you do this technique. Once you are ready, mi passi il laser, Aja? Senza accenderlo, usiamo solamente l'applicatore con sulla punta, il piccolino. I don't switch on the laser just to see the technique. Mettimi il microfono vicino a me la macchina, se no tiro troppo. Well, while I'm in this position, I can, now this table doesn't move. If you have the table that moves, you fit over with the table. Now I don't have the table, so I have to bend my knee because I solve his back, my back starts aching. So protect your back. So find out the point and you stimulate the nerve root following, for example, L4 on L3, for example. Okay? This could be an idea. And this strategy provides the most energy that you provide to the structure. If you have the patient on the stomach, you have the extended position, you disperse part of the light beam over the spinal process. Depends on the anatomy, okay? Sorry?
Same position.
Yeah, you can, as I told you. If you want, you can make the patient and put the patient in sitting position, but if you work on the patient, stay on your back, now relax. If you put the patient like this, maybe without any point to leave the weight, is very painful. So if you have the patient in a sitting position like this, and you bend forward and you apply pressure over your elbows, for example, you loosen the structure, you reduce the compression of the disc, you can also work in that position as you prefer. Depends on your patient. Okay, you cannot add the rotation in that position. Okay, this position in a seated position is because your patient maybe is an old lady, maybe is so painful the situation that you cannot put the patient over the table because you cannot, it's too much painful. No, no, no. So you start treating him on the sofa, on the chair. You can. Sometimes happens because, as I told you, on the screen, on the theory, everything is easy. When you find the real life, you have a lot of troubles, a lot of problems.
someone that cannot go on the table because maybe you have this, it doesn't move, it's too fat, he cannot go over the table. Happens. Well, if you want to make the best simulation over the nerve, you do this biostimulation. And now we are talking about the best biostimulation. But the global approach that I told you before still involves the lymphatic system. So what I mean, I still open the lymphatic station if I can before the treatment of the root. I stay on the stomach, on your back, please. Because if I have pain over the root, I have mechanical compression, maybe due to herniated disc or arthrosis. This type of mechanical action is not, you cannot release immediately with the laser. But around all the suffering root, as for the tendon, we have swelling, we have inflammation. Also, this swelling creates compression. So sometimes we have irritation of the nerve with swelling around the root, but we don't have bigger herniated disc. We just have irritation and inflammation all around. If I open the lymphatic station and I treat the lymphatic station, we still have the approach of the tendon, the approach of the sprained ankle. We open the lymphatic system to obtain better drainage, so we supply the biostimulation that we do over the nerve, and also we reduce the inflammation of the nerve, and also we reduce the swelling around the nerve because it's less inflamed also, but we produce also better drainage over the structure. So we disperse part of the liquids around the root, so less compression due to the liquid, better effectiveness. My patient stays better. And for the same approach, we can treat the muscle of the spine. Well, for opening the lymphatic station that we open, for example, for the back, is the Sealy cistern, the cistern of Kilo, the cistern of OK, lot of name. The cistern is only on the left side. He follows the course of the aorta and is quite close to the belly bottom, 2 fingers upper than the belly bottom. Here you go with the laser and make the biostimulation. You open the lymphatic system with the same tool that you see for the knee, for example. And then we open the 2 femoral clusters. You know, the lymphatic system splits in 2 from the cistern of Kilo, close to the aorta, so is only one on the left side. Then go down, split up, like the veins as well. So we have left one and right one. On the line that cover the belly bottom and the superior spine of the iliac, we found here the femoral cluster. So we create vascularization. We open the lymphatic station on the femoral. Then we put the patient in the side position and we make the biostimulation over there. Please, on the side again. At this point, if you want, please bend the knee. You can make biostimulation with the laser on the nerve. After, no more on the nerve, because if you exceed too much energy over the nerve, too much pain, you exceed the dose as well for painkiller. You know, paracetamol is good. So you take 1 pill. If you take 5, no more good, because it's toxic. As well for the laser. We found with the laser we have more precision because we have more study, more papers. So we know better from all the research that we can provide the correct dose. We discuss about joules, time, centimeter squares. With the TECAR, you see, we don't have enough data because it's younger technology. So we discuss about power, how much time, I don't know. No one says 10 minutes and enough, because we don't have enough data to say, give this joule, give this time. We discuss a lot with the patient, with the feeling of the patient, because we see the patient stays better, but you don't have enough data, like laser, to provide the proper dose. With the laser, we can. So once we find the structure, we stimulate the nerve. And then outside the nerve, we can stimulate with the spherical, so mechanical action, or with just the applicator, larger or little, the muscle, in order to make vascularization, loosen of the muscle with the nitric oxide that you provide with the laser. You control the heat because nitric oxide provides blood. You have dilatation of the vessel due to chemical, not to the heat. So you have loosen of this muscle, you make capillarization of this area, and you can also make massage, manual therapy to loosen the thickness of this muscle because connected to the pain on the nerve, for sure we have also stiffness and spasm of the muscle of the back. You lose the spasm, the patient passes from this position to, okay, less pain and I can stay more in a straight position and not bend like this, typical position of patients suffering for back pain or sciatic pain. And this is the approach, for example, of the early stage, the first stage. Maybe you meet the patient twice a week, 3 times a week. At the end, Monday and Friday, your patient say, okay, now I can walk. I still feel numbness on the nerve, but now it's better. So you still make this stimulation, but maybe now you add just more exercises, your chest exercises, to make better control of the transversal muscle, for example, or you add more energy, especially on the muscle, because on the nerve you still make this stimulation, and on the muscle you give more because your patients stay better. This is an approach that we can have over neuropathies. If we treat, for example, gonarthrosis, is another word, is another way, we have to think about, for example, the articulation and the swelling around the articulation. So, on your back, please. Maybe we have the arthrosis of the knee, typical.
I have a question on the back.
Yes.
You use it on acute stage, going inside the acute stage.
For the chronic?
What about chronic?
Yes. Okay.
سؤال تاني؟
About the chronic, you have the...
Again.
You ache chronic. Okay. For the chronic, could be useful, and you can find a lot of results also with the TECAR in that case. I'm sure that with the TECAR, with the chronic suffering, you don't have any problem. At the beginning, you are worried about don't provide too much energy and provide more pain to the patient. If it's an area, a pain, month and month that you suffer, you can give more heat, and maybe this stiffness, this pain referred on the back required a lot of oxygen, a lot of vascularization, a lot of loosen of this tension. So you need also the heat, and on this side, diathermy is more performing, for example. So you see the doctor speaking, stimulation of the nerve, stimulation of the muscle. Yeah, for sure. I prefer using diathermy in that case because in few sessions, my patient stays better. So he's happy because he recovers quicker and has to pay less. Depends on you. Maybe you want to earn much more money, but looking on the side of the patient, in maybe 4 or 5 sessions, you get results because, yes, you have to make every time the correct assessment. I have to check with him what's the problem. The problem is from the disc, the problem is on the nerve, the problem is on the weakness of the muscle of the back. I have the problem of instability of the back. With the TECAR, no results. No results. Because if, for example, you treat a female playing volleyball, they have instability of the back, no results with the TECAR.
My question on pain on chronic patient with local pain.
You can provide diathermy. And in that case, I always suggest to open the lymphatic using the diathermy because with the capacitive, you're still able to open the lymphatic and then move to the spine. Look on the side of the TECAR, you are not more worried about the position of the patient because you work with electricity. Once you close the circuit, the electrodes flows. So there's no the problem of the reflection of the light beam that you have with the laser. So you can still treat your patient on the side if you like and you want to work manual and biostimulation with the TECAR. If you want to make only vascularization, biostimulation with the TECAR, you have the patient on the stomach, and you make the stimulation or with the TECAR as you want. You can do it as you prefer.
Thank you.
You're welcome. Looking, for example, for gonarthrosis, and then I free you after this, and thanks for the attention. You look for the problem of the chronic suffering of an articulation. Typically in Italy we have the knee, we have the prosthesis of the knee because we have a lot of arthrosis around the knee. Before the prosthesis, we can do something to supply the patient and to relieve the pain. Now the problem is if we still have cartilage or don't. If we still have cartilage and we want to save the cartilage and make biostimulation over the rest of the cartilage, we can choose from laser and TECAR in that case. And looking for a chronic pathology, maybe also is more performing the TECAR therapy. But sometimes we have acute inflammation over a chronic situation. So you have to find out the situation. Maybe you have a patient with a radiography and you see a lot of arthrosis. But this patient talking with the patient say, I was good until last week. And now I start aching. So that situation is acute situation over a chronic situation. So maybe be careful with the TECAR in that situation. You can manage with the diathermy, but you can, if you have the two devices, maybe you can decide to work with the laser, because sometimes it's not so completely different the situation, only acute and only chronic. Sometimes you have two gray points from white and black. Well, still working how the machine works, if I have acute over a chronic, working with the laser, you still open the lymphatic, you understood. And the problem is all the liquid around the knee. You have to remove because you have a lot of swelling around the knee. So working on the effect of the laser, you have biostimulation with the laser, or you have anti-edema effect of the laser. It means you provide the wavelength that you have with the correct modality of the emission in order to provide nitric oxide. You know, with the laser, you provide energy, nitric oxide for vascularization, and ROS. In that case, it's not a muscle lesion. You don't want to make biostimulation. In that case, you want to provide as better as possible drainage of the structure. So anti-edema effect, the machine calculates the right dose for your purpose, reduce the inflammation, and especially reduce the swelling all around. Then, if you have cryotherapy or if you have enough time for the patient, you ask for other exercises, you loosen the muscle of the thigh, because for sure over chronic pain of the knee, you have to loosen as well the quadriceps. After 10 minutes, after 15 minutes, your tissue are ready to receive more energy, okay, because you still work over a structure. I make every time this example. Working with the laser and TECAR is like giving water to a plant. Everyone agrees that giving water to a plant is good. But if you give no enough water, no results, and the pain and the plant suffer. If you give too much water, that is good, but too much, you kill the plant as well. Every structure can accept some energy. So if you exceed that energy, toxic. So you open the lymphatic, you stimulate the drainage, then looking on the position of your patient for the same purpose and for the same way you put the patient on the side, you add flexion for the spine. For the stimulation of the knee, if you have the knee in that position, you see the cartilage is covered by the kneecap, okay? So you add flexion. So now you can work over the kneecap, move the kneecap, and you remember you have to be orthogonal, but you follow more and you go stimulate underneath the cartilage, because the problem is the cartilage between the femur and the kneecap. If you have the patient like this, you despair. You still have this, but it's not so helpful. Here, you expose better also the cartilage of the femur, okay? And also you can reach better the cartilage of the patella, okay? And also in that position, because we are talking about not chondropathy, is gonarthrosis, means all the knee is involved. We want to stimulate the meniscus, for example, to stimulate the lateral meniscus over there. If we add internal rotation, we expose more the lateral meniscus, so we have the tendon over there, and we see and we can reach more the lateral meniscus as well. If you want to go back to the internal meniscus, we add external rotation, so the fibers and the wall, because you know you can reach only the external wall of the meniscus, the inner part of the meniscus we cannot reach it at all. But the most vascularized part of the meniscus is the wall, the external wall, that can regenerate, can be reached by the laser, so you can perform the stimulation like this. If you do the stimulation like this as well, you lose part of the energy. If the situation is so chronic, so big swelling, so much time the patient suffers for it, you can use the diathermy. You can use the diathermy using, at the beginning, the capacitive, because the purpose is to remove all the liquids. You know, you have great swelling over the knee. Liquids means water. Water has good conductivity. You work at the beginning with capacitive because you want to stimulate this. If you stay just only over the knee, the same problem. You don't open the lymphatic first, so you stimulate, you move the liquid, but here you still have congestion. Remove the congestion, stimulate the liquid, ask for movements, ask for exercise to your patient in order to move the knee and make more circulation of the the knee inside. We have the inner part of the articulation. We have liquid inside, and the liquid of the articulation. Well, the synovium. Sorry, thank you. I'm quite tired also me. So we stimulate the synovium, so the synovial liquid is moved because we have the problem. Also, the synovial liquid is more dense. If we move, we reduce the density of the synovial liquid. So the synovial liquid provides the supply for cartilage. Cartilage is not vascularized directly by vessels. Is fed by the synovial liquid. Okay, so once we solve that great congestion, so we open the liquid, we treat the capacitive, we active movement, so the synovial liquid pass to a more dense state to more liquid state, then we can use, for example, the resistive, because resistive go deeper, can stimulate the structure poor of water, like for example, the cartilage, like the bone, we have enough frequency, you see, and then still ask for exercises, looking for the pain of the patient, because if you provide pain, you reactivate the inflammation. So respecting the pain of the patient and looking for this type of feeding the cartilage using the diathermy, in that case, you can reach results. Okay, you cannot bring back the patient of a younger knee, but you can manage and take longer time to undergo to the surgery, for example. Because, for example, in Italy, the problem is you cannot do the surgery the day after. You have to wait, and the patient's still aching, and the quality of life of the patient go really down. So the more you are able to relieve pain, in that case, you really help the patient. You don't heal the knee because you cannot. The arthrosis is developing and is too far now. But you can really reduce the pain and make the patient happy and improve his quality of life. And then that's enough, guys. Thank you so much for your attention. Thank you for your help.
Thank you for patience.
No. Sorry, I lose the word at the end. Well, thank you, guys. I really hope that you appreciate it's like to share experience is not like do like this because we do best. It's like sharing from colleague, I'm a physiotherapist, and like sharing experience, and could be an idea of working. That's it. You're welcome.
شكرا جزيلا لوجودكم معانا النهارده ان شاء الله، ونكرر الايفنت ده مره واثنين وثلاثه ان شاء الله، وبكره باذن الله عندنا في ايفنت قوي جدا جدا على البلفيك فلور وكل الانترست بالبلفيك فلور، وهيبقى التريننج بكره او الورك شوب الى حد ما براكتيكال بالفي ار تكنولوجي، لان احنا دلوقتي وكلاء شركه وان كليك في مصر والامارات والسعوديه، دي في ار تكنولوجي فور اديوكيشنال، واحنا قدرنا ان احنا نديفلوبمنت بروجرام للاديوكيشنال كاناتومي. وبكره ان شاء الله هيبقى موجود معانا الدكتوره اميره ناجي جامعه القاهره والدكتوره دعاء عثمان جامعه القاهره ان شاء الله، فاللي حابب يشرفنا يبقى شرف انكم تكونوا موجودين معانا بكره ان شاء الله على البلفيك فلور. اوكي، ميرسي جدا لحضراتكم وحضراتكم نورتونا، وشكرا لحضراتكم. شكرا.